Dear audience, dear chair, my name is Petra Papócsi. I am an oral surgeon and a PhD student at the Department of Maxillofacial Surgery and Stomatology at Semmelweis University. My supervisor is Zsolt Német and my SMS is Alex. My vision is to learning and utilizing the latest techniques in case of patients with jaw fractures, and my mission is to using a faster and more comfortable splinting technique during the IUT. You can see here my specific goals. At first, to investigate the effectiveness and safety of the currently used fixation methods in treatments of jaw fractures, and my second goal is to examine the maxillofacial injuries related to the e-scooter usage. My first project is a systematic review and a network meta-analysis. In case of jaw fractures involving the dental occlusion, we should re-establish the occlusion with the intermaxillary fixation. The maxillomandibular fixation is the same word. It's important for us because the mandibular fractures are the second most frequent facial injuries, more common in males in their 20s, and these fractured ends must be fixed because the absence of the proper bone healing, there could be bite functional differences or aesthetical and psychological differences as well, or there could be an inflammation. The fixation can be achieved in a conservative way with a close reduction or in a surgical way with internal fixation and open reduction. In the first picture, you can see the gold standard Eric arch bar when we use two arch bars fixed by interdental wiring. It's really time-consuming technique and it's painful for the patient as well. And it can cause many gloves, puncture, and needle stick injuries. That's why they started to use the IMF screws. These are 4 or 6 self-tapping screws, and it's shorter to use, and it's less painful for the patient, but there could be many iatrogenic injuries. The hybrid MMF technique, as you can see on the third picture, is to synthesize the previously mentioned two techniques, the advantages and the disadvantages as well. Our aim was to compare these currently used techniques and reduce the complications and the surgery time. Our clinical question is that is there any difference in effectiveness and safety between the currently used methods in treatments of jaw fractures? Our population are adult patients with jaw fractures who need the intermaxillary fixation. The intervention and comparator are the Eric arch bar, the IMF screws, and the hybrid technique, and you can see the main outcomes in the table. We would like to create a time-efficient and safe technique which is comfortable for surgeons and patients as well. We conducted our systematic search in 4 main databases, and you can see here our final search key. At first, we had more than 20,000 hits, and after the duplication removal and the selection, we have now 29 eligible full texts. We divided the outcomes into safety outcomes and efficacy outcomes, and our statisticians has made all the analysis for RCTs only and for RCTs with non-RCTs together. Due to the time constraints, I would like to talk about the 2 main outcomes. At first, the application time, which was measured in minutes. On the left side, you can see the network plot where the dot shows the treatment types and the lines are the number of the comparisons. On the right side in the table, you can see the P-score ranking. The higher the value is, the better the treatment is. So we can see that the IMF screws reached the first place. So it was the most time-efficient technique, followed by the hybrid technique, and the Eric arch bar was the most time-consuming. In the leaky table, we can see the values of the point estimates and the confidence intervals. It shows that application of the IMF screws is about 47.33 minutes less than using the Eric arch bar, and the application of the hybrid technique is about 33 minutes less than the Eric arch bar. These results are statistically significant and clinically relevant as well. The next outcome would be the iatrogenic injuries in relation to patients. It means the tooth vitality loss or the root injuries which are caused by self-tapping screws. On the left side, you can see the network plot again, and the P-score ranking shows that the less iatrogenic injuries happen when we use the Eric arch bar, followed by the IMF screws, And the most happens when we use the hybrid technique because we have a lot of screws to use. In the leakage table, we can see that third part of iatrogenic injury is happening when we use the Ricard bar instead of the IMS screws, and it's the fourth or fifth part in case of using the arch bar instead of the hybrid technique. These are statistically significant values and clinically relevant as well. You can see here my first project progress. The strengths of our analysis is that it's the first network meta-analysis in this topic. We had a homogeneous population and direct and indirect comparisons as well. But the limitations were the small case numbers and the various units of measurements. In conclusion, we should say that the IMF screws and the hybrid technique are more effective in application and removal time, oral hygiene, patient acceptance, but there's a higher risk for iatrogenic injuries and inadequate occlusion. So we would like to recommend the use of the IMF screws, but we should discuss with the patients about the advantages and disadvantages of the techniques. We need more multiple arm studies at the same time under the same condition with higher case number. So our manuscript is under review in Journal of Craniomaxillofacial Surgery, which is a D1 journal in our area. My next topic are the maxillofacial injuries related to the e-scooter usage, is the systematic review and the meta-analysis. The e-scooters are the part of the urban micromobility because they are an environmental friendly way to transport, they are highly available, and they are cheap. But there are no restrictions for using helmet, using them under alcoholic intoxication, and there are no speed limits. It's important for us because the most common injuries, as we can see in our clinic as well, are the face and head and neck injuries, especially in case of young, drunk people at night. So we would like to highlight this danger and identify the risk factors. Our clinical question is that what are the risk factors and what is the prevalence of different maxillofacial injuries in adults related to the e-scooter using. We use the COCOPOP framework, and we would like to examine these maxillofacial injuries and risk factors in context of the e-scooter using in adult patients. So we hypothesized that the prevalence of these injuries due to the e-scooter using are more when there's no helmet and the patient is intoxicated. You can see here my systematic search and the final search key. At first, we had more than 1,500 hits, and after the new selection, the duplication removal, and the citation chasing and the references, we have now 43 eligible full texts. Now we have made the data extraction, and we would like to make our topic more interesting. So we would like to examine not only the face fractures and the factors influencing them. We would like to see, in collaboration with our statisticians, a broader view and highlight the treatment options. And these are associated with the complication rate, but now we are working on it. You can see here my specific goals again. At first, the effectiveness and safety of the currently used methods in treatment of jaw fractures, and the second project are the maxillofacial injuries related to the e-scooter usage. And I would like to thank you for your attention with the words of Dan Brown, that everything is possible, the impossible just takes longer. Thank you.
I would change a little bit the title, be more specific for the second study, like characteristic of injuries or something like that. So it's something that's missing from there. So the outcome is missing. Just a small note. Do you have any idea how complicated to correct if there is a iatrogenic injury during? It happens during the surgery, as far as I understood, or?
It happens during the intermaxillary fixation application because we use these self-tapping screws under general anesthesia, and if the surgeon is not the best or didn't have many cases, it can happen that they drill it into the root. But it happens, I think, maybe the 10th part of the time, and the vitality loss is less because the vitality can. So if the tooth lost the vitality, it can be permanent or temporary.
Okay, so this happens during the surgery, basically.
Yes.
Yeah. And can it be avoided by CBCT planning or?
We could, but we don't do that because I think because of the financial background.
Okay, so you just send to the endodontist to correct.
Yeah, I think it would be longer time to make the planning than the surgery with the IMF screws and the open reduction internal fixation as well. So I think maybe that's why.
This is something which you have to clarify in the discussion, because this is the aspect of the different, the same thing.
Regarding translational medicine, my question first would be, what are you currently using in your clinic? What technique? Regarding study 1, of course.
We are using the Eric Arch bar because it's, I think it's financially the best for us, and anybody can does it. So, for example, a resident doctor or a specialist as well.
Mm-hmm. You said that the IMF screws are in place 1 regarding the application time and 47 minutes shorter in application time compared to the Eric Arch bar. How long does the application of the Eric Arch bar take in total then?
The Eric Arch bar application is about 60 minutes to 120 minutes. It depends on the doctor or the surgeon.
Exactly to what you said right now, in the study, did you consider the level of proficiency for the application? As you said, this might play a role for the time. So the level of proficiency of the doctor applying the Eric Arch bar or any other technique, as you said, it could take from 60 minutes to 110, 120.
Yes, and it depends on the situation, because if these fractured patients are not, they don't have the best oral hygiene, and they don't have many teeth, so it depends on how many teeth and how many occlusion pairs they have.
All right. Since you would rather recommend as a conclusion the IMF screws or the hybrid technique, is there any plans in your clinic to also implement this then, as we had before, as the translational medicine goal is here as well?
I hope so. I will discuss it with Joel. But
right.
It was my aim when I started this research, because in our clinic we don't really like the Eric Arch bar because it's really time-consuming and painful for the patients. So that's why we started this meta-analysis to make an article and a meta-analysis, and now I have evidence for that.